to ask questions on a case will be going on. And without any further delay, I will ask if any IPS president and secretaries are there, they can give you brief introductions. After that, Dr. Achika can take over and introduce our biggest speaker today, Dr. Sandeep Agarwala, who is a renowned pediatric surgical oncology with more than 25 years of experience. Dr. Achika and Dr.
Hello.
You can, if Dr. Our Vishwas and Dr. Vikesh is there, they can just introduce themselves.
Vishwas sir is there? I think sir has not joined. Sir, I would like to invite Vikesh sir to say a few words about this webinar. Vikesh sir is there? Sir, he is also not there. So, without any delay,
then you introduce, sir.
Yes, sir. I will like to invite a speaker for this webinar, who is a very eminent speaker, and Professor Sandeep Agarwala, sir. He is a professor and head at Department of Pediatric Surgery at AIIMS, New Delhi. Sir is faculty at AIIMS since 1994. Sir has a special interest in oncological, thoracic, and neonatal surgery. Sir has published more than 395 publications, 95 chapters in books, and editors of 3 books. Sir has been section editor in surgery and Indian Journal of Pediatrics. Sir is reviewer in many index journals and chair of surgical section of the IAPS. Sir has been invited as a faculty for master class in pediatric surgical oncology of APSO. Sir was executive board member of APSO. There is and also board member of Asian Association of Pediatric Surgery. Now, welcome sir as a speaker, and thank you for accepting our invitation. Now, I would like to invite all the moderators for this webinar. First of all, I will like to invite Dr. Anand Pandey, who is a professor at Pediatric Surgery at King George Medical University, Lucknow. He has an index of 20 and has published more than 100 papers in national and international journals. He has been reviewer of many journals, index journals, and member of editorial board. He has 5 patents in his credit. His area of interest are anorectal malformations, pediatric surgical oncology, especially hemangioma and tracheoesophageal fistula. He has been EC member of RIPS section of IAPS, and currently he is a EC member of the Central Zone of APSO section of IAPS. Our next moderator is, welcome Dr. Anand Pandey. Next moderator is Dr. Vijay Kundal. He is additional professor and head at Department of Pediatric Surgery. Hello. Hello.
Muted. Can you mute everybody else except for the speaker and our moderator right now?
Dr. Vijay Kundal is currently additional professor and head pediatric surgery at AIIMS Jammu. He is also associate dean at AIIMS Jammu. He has published more than 50 papers in national and international journals and presented more than a dozen lectures in national conferences. He has been a reviewer and editorial board of many journals. He is EC members of the North Zone IAPS and APSO IAPS, section of IAPS. His area of interest is pediatric urology and pediatric minimal invasive surgery. And I would like to invite the next out of the box for the discussion. Our next moderator, that is Dr. Swaminathan A. He is assistant professor pediatric oncology in the medical oncology department, JIPMER Pondicherry. He is also many publication in national and international journal. He is a member of NHL Indian subcommittee of Indian Pediatric Hematology and Oncology Group. His area of interest are pediatric solid tumor, pediatric acute leukemia, supported group, and pediatric brain tumor. Welcome, Dr. Swami, and welcome all moderators. Now, I am handing over this webinar to all of the moderators. I request moderator to take the question and make this webinar interactive. Over to you all.
Thank you, Dr. Achika. Welcome, everyone. And since we are already 10 minutes late, so I hand over all the discussion to our speaker, Dr. Sandeep Agarwala, sir. And it's my honor to be here in his presentation. Sir, Sandeep, sir.
Thank you all. Thank you, the Executive Board of APSO, for giving this opportunity to take this lecture. This will be specifically on genitourinary RMS, and I have positioned this lecture as a case-based study. So we'll have some cases and see how we use these cases to learn the staging, the diagnostic, the management, and the outcome of these patients. I hope you can hear me and see the screen.
Yes, sir, loud and clear.
So rhabdomyosarcoma is the commonest childhood sarcoma. In fact, it is the third most common extracranial solid tumor in children. And genitourinary RMS is the second most common site of RMS following head and neck RMS. International classification of RMS has divided RMS into these categories, which we commonly know, and the most common are the embryonal and the alveolar categories. As I said, genitourinary RMS forms about 25% of all rhabdomyosin children, and this is classified as unfavorable site or favorable site. Amongst the unfavorable site are the bladder prostate for the GURMS, and the favorable sites are uterine, vaginal, paratesticular, and labial. This will be useful when we are doing the staging of these tumors. 20% of these patients have metastatic disease at presentation. Most of the metastasis is in the lungs. And that is why it is important to evaluate the lungs when we evaluating these patients for proper staging. So we go on straight to the first case, which is a case which I picked up from my case records. It's a case of 2008. So this 18-month-old female child presented to us with abdominal distension and lump in the lower abdomen for 3 months with severe pain for last 2 days only. She had normal appetite and weight gain. There was no hematuria, pyuria, no vaginal discharge. The child was pale, irritable, afebrile. There was a hypogastric mass as seen in the picture extending from both iliac fossas. Right side was greater than the left side. It had to be defined. It was slightly mobile side. The rectal examination in this child showed that the mass was bimanually palpable. It was a firm mass. It was palpable anterior to the rectum. Rectal mucosa was free and retrorectal space was also free. So we come to the differential diagnosis based on this clinical examination and the findings. And so we have these listed down here as pelvic neuroblastoma, ovarian tumor, sacrococcygeal tumor, bladder tumor, uterine tumor, and mesenteric or duplication cyst. Now, sacrococcygeal tumor is retrorectal. So it could be a bladder tumor, uterine tumor, ovarian tumor, low down is only 18 months old. So how should this child be managed? The management is both diagnostic workup and the treatment that we give to the child. So baseline investigations were done, and for the pain, paracetamol was administered. Anemia was corrected by constipation was corrected by glycerin enema, and adequate nutrition was by enteral feeding in the time that we worked up this patient. Patient was anemic, as I said. It was normal. Prothrombin time was normal. Alpha fetoprotein was also normal. This child. So unlikely to be an ovarian malignant germ cell tumor. And as I said, examination showed it is not a sacrococcygeal tumor. Found a large solid mass from the pelvis with areas of necrosis. Bilateral kidneys were normal. There was minimal fluid and the liver was normal. Subsequent to this ultrasound, a CT scan, contrast enhanced CT scan was done, which shows a large heterogeneous mass from the pelvis with central necrosis and infiltrating the lateral part of the urinary bladder. It could be seen arising or infiltrating the dome of the bladder here, as pointed out. There was mild grade 1 hydronephrosis, liver, and normal, this child. So now what is the diagnosis? With this kind of a CT scan picture at this age in a child with a solid mass arising out of the pelvis seen infiltrating the bladder, we made a clinical diagnosis of rhabdomyosarcoma from the dome of the urinary bladder. How do we confirm this diagnosis? Obviously, we need to do a histology for which a core needle biopsy is done. This is the core needle biopsy, which shows an embryonal rhabdomyosarcoma with spindle cell formation in this. And so the pathologist returned it to us as an embryonal RMS spindle cell variety. And we know it is arising from the dome of the bladder. Stage the tumor, risk categorize so that we can categorize the further management of these patients. How do we stage these patients? Now, rhabdomyosarcoma needs all these investigations for staging. The CT scan of the chest, initially lung is the commonest site, bone marrow aspiration and biopsy as bone marrow could be a site for metastasis, skeletal survey, and we also do a technetium for these patients. The two staging systems used in combination for rhabdomyosarcoma, we still use the clinical grouping, which is a surgico-pathologic staging as it is dependent upon the resection of the tumor. The pre-treatment TNM staging is also used by RSG, and in combination, we come to categorization. This is the clinical group staging. Stage 1 is localized, completely resected. 2 is gross complete resection with microscopic positive margin. 3 is biopsy only. And 4 is distant metastasis. That is in gross, this is the staging of clinical grouping. The TNM staging uses all these factors: sites, tumor invasion, size, regional lymph nodes, and metastasis. Favorable site or unfavorable site, as I said, amongst the GO-RMS, the bladder, prostate are the unfavorable site, the rest are favorable site. Tumor invasion, T1 confined to anatomic site, T2 is beyond anatomic site, and size less than 5 centimeters or more than 5 centimeters on CT or MRI. Regional lymph nodes, if lymph nodes are positive, it is N1, otherwise N0. Status unknown is NX. Metastatic disease is M1. And because this is so much things, clinical grouping and clinical TNM staging, it is best to mark out on the chart and then come to actual staging. So TNM staging, stage 1, all favorable sites are stage 1, except the metastatic sites. So all unfavorable sites are stage 2 or 3, depending upon the lymph node status in these patients. And any metastatic disease is stage 4. So as we know that except bladder and bladder prostate, all other genitourinary sites are favorable sites. So a lot of genitourinary RMS comes in the favorable site. But then most common site is the bladder and bladder prostate, which are unfavorable site. The risk categorization is done according to the outcome of these patients. So the risk, low risk is divided into 1 or 2 or A and B. There's intermediate risk, which has an outcome of 50 to 70%, and high risk, which outcome of less than 35%. So then when we have all these charts, we can mark out in this patient what is the risk categorization. Now in this patient, I'll just delineate the staging of this patient. Now, what are we planning to do? Should we do an upfront resection or biopsy followed by neoadjuvant chemotherapy of the tumor and various other factors in this tumor? This patient underwent an upfront resection, including a small part of the dome of the bladder, because the patient had a lot of pain and we were worried about hemorrhage and torsion with inculated mass. On surgery, there was a large necrotic mass from the dome of the bladder. No lymph nodes were involved. There was no ascites. Gross section was done with no spill in this patient. So ultimately, we got embryonal rhabdomyosarcoma spindle cell variety from the dome of the bladder with microscopic margins negative and lymph node negative. So now we come to staging of this patient. So this is clinical group 1A because it was confined to the organ of origin. In the TNM staging, it is an unfavorable site. It was localized to the bladder. It was more than 5 centimeters. Lymph nodes were negative and it was non-metastatic. So it comes to stage 3 according to this table. When we look at the risk categorization, in the risk categorization, TNM stage 3, clinical group 1, unfavorable site, embryonal rhabdomyosarcoma. So it is, according to the RMS risk categorization, it is low 2 or low B, low risk type 2. And according to this, the chemotherapy decided on this. So final diagnosis is spindle cell embryonal sarcoma of the dome of the bladder, clinical group 1A, TNM stage 3, low risk 2. So now we have to decide what is the further management. So because in this patient, we have done an upfront resection. All patients of rhabdomyosarcoma require adjuvant chemotherapy. Otherwise, the recurrence rates are very high. Whether adjuvant RT is required or not will depend upon the tumor and its location and the resection. So what is the chemotherapy for genitourinary RMS? So this is according to risk categorization. Low risk 1, type 1 is given only 2 drugs, vincristine and actomycin D for 45 weeks, or we can give VAC/VA for 24 weeks. All the others, low 2, intermediate and high risk, are supposed to be given VAC chemotherapy, which is given for a good 54 weeks. This is details of the chemotherapy, which I will not go into right now. So this patient received adjuvant therapy for 42 weeks, VAC. VAC includes vincristine and cyclophosphamide. This A is not adriamycin. So VAC 42 weeks, no radiotherapy was given because it was a microscopic negative, clean resection, and no spill, no lymph nodes. Is done in these patients. Clinical and radiological follow-up is done by ultrasound and CT. We do it alternating ultrasound and CT every 3 months here, and then 6 monthly thereafter for at least 2 years, and then annual follow-up clinical and radiological is done. There are no tumor markers, unfortunately. So radiological and clinical examination is all that is required. This child was disease-free at 5 years. At that time, at 5 years of follow-up, she complained of frequency of micturition, and because of that, she was advised to undergo an MCU, ultrasound, and neurodynamic evaluation. Now here, I'm continuing this case to delineate the long-term complications in these patients that can be seen. This is all in this patient only. This is the MCU, which showed a small capacity bladder with no reflux and no PVR. Ultrasound did not reveal any hydronephrosis, but did show a small capacity bladder with no PVR. This is a urodynamic examination of this patient, which showed a very low capacity, poor compliance, high pressure system with no uninhibited contractions. Now, this is a very risky kind of a scenario because gradually, because of the poor compliance, and they will gradually develop upper tract damage and may go into end-stage renal disease. So this patient was started on tablet oxybutynin, and the plan was to follow up with renal functions, GFR estimation, follow up urodynamics and ultrasound at 6 months to see what is happening. And if required, and if the pressure remained high in spite of the pharmacological treatment, then we would go ahead and augment this bladder. Now, this child at 15 years follow-up, that is the age of 16.5 years. This is the last follow-up in December 2024. She had normal growth and development, was going to school in the 10th class, no frequency, no enuresis, renal functions were well preserved, GFR was maintained, and was having normal menstrual cycles. So that is the follow-up of this patient. So this is a bladder rhabdomyosarcoma arising from the dome of the bladder, which could be primarily resected upfront and given adjuvant chemotherapy, and had the complications of chemotherapy, especially cyclophosphamide, resulting in a low capacity bladder. Now I'll go on to the clinical case 2, which is out of the case file of 1999. This is a 3 and lump abdomen for 1 month. Hematuria for 15 days, trianguria 10 days, and dysuria for 10 days. This child was investigated with an ultrasound which showed a mass in the bladder. An MCU at that time also showed a mass, a filling defect in the base of the bladder, and the chest X-ray showed multiple cannonball kind of metastasis in the chest in this patient, 3 years old. This is the CT scan of the patient, which is showing a large mass arising from the bladder base. I have not put all these scans. I've put some specific scans. And this is the coronal section showing the large mass in the bladder base in this patient. The chest CT was normal in this patient. A core needle biopsy was done, which showed embryonal rhabdomyosarcoma. The metastatic workup in the bone was negative. As I've already shown, the chest was positive in this patient. The patient was started on neoadjuvant chemotherapy, which was again WAC, as this is again high risk category, this patient. So staging, we come again, we look at those 4 because of distant metastasis. TNM staging, stage 4, unfavorable site because of metastatic disease. When we look at the risk category, it is high risk because TNM stage 4, clinical group 4, in unfavorable site and embryonic rhabdomyosarcome. The outcome for high risk rhabdomyosarcoma is poor, less than 35% patients make it to the long term. Final diagnosis prostate, clinical group 4, TNM stage 4, high risk category. And now what is the further management for this patient that we did in 1999? Weeks was reassessed. There was a good partial response, but there was residual disease. He was advised surgical resection, explained the risks of resection of the bladder base, which included incontinence, need for CIC, and also recurrence. The parents refused surgery. And because they refused surgery, we had no alternative but to go on with the chemotherapy, give the local external beam radiotherapy of 45 grays, and we continued till the end of the chemotherapy. This is what, and the tumor at the end of chemotherapy, this is end of chemotherapy scans, there was complete resolution of the tumor. And this patient received radiotherapy also, as I said, in between. And this is one of the first cases that we came across a large number of cases after this where the parents refused surgery when we explained the outcome of the bladder base and bladder dissections. And so a lot of our bladder prostate RMS have not been operated upon. They have got chemotherapy and radiotherapy, and a number of them are in CR and surviving. This child now, in December 2024, was disease-free at 28 years of age, no aneurysms, but was azoospermic. This is because of the cyclophosphamide, had bilateral sacroiliac joint arthritis, probably radiotherapy-induced, and works as a professional newspaper reporter, and is otherwise okay. To summarize, bladder prostate RMS is the most frequent among genitourinary RMS. The median age is about 3.5 years. It can involve the dome, but mostly it involves the bladder base of the trigone area and with or without the prostate. They are embryonal rhabdomyosarcoma. Nodal involvement is uncommon, so nodal biopsy is not recommended in these patients, and this is counted as an unfavorable site of rhabdomyosarcoma. Prostatic tumors usually present as a large pelvic mass with strangury and constipation, and they are solid rather than polypoidal and often metastatic to lung and bone marrow. While bladder tumors are pelvic masses which present with hematuria, passage of pollen, they can come with urinary retention and over incontinence. They are usually botroid, that is polypoidal, and are not metastatic. This is mild differences between prostatic and bladder tumors. Pelvic exentration used to be the best form of treatment in the past, but is no longer initial therapy. Partial cystectomy may be done for the dome tumor, as I have just shown in the first case. Excision of the residual nodule of chemotherapy is recommended between 9 and 12 weeks of chemotherapy, and that is called the second loop operation. Radical cystectomy still may be required in this patient, or cystoprostatectomy may be required for poor response with neoadjuvant chemotherapy or local recurrence, and this will require extensive urological reconstruction in these patients. Bladder preservation without compromising survival is shown to be in about 2/3 of the patients in IRS-3, and this is remained same in the subsequent studies. So we understand that with all our therapy, still about 1/3 of the patients will require cystectomy for preservation of life. But unfortunately, a lot of these patients in our scenario refuse the surgery, and then either we lose the patients or we change to auto response to therapy. The late effects are common in bladder prostate RMS, both because of the disease and because of the treatment that we give. There is usually delayed puberty. Incontinence is very common because injury to the bladder neck because of surgery, and small capacity bladder is usually either because of surgery or because of cyclophosphamide. Upper tract deterioration occurs because of the high patients. They are prone to early development of transitional cell carcinoma, which is an effect of cyclophosphamide, basically. Other malignancies are also common, but transitional cell carcinoma is something which we have to look at when these patients present with hematuria later in the follow-up. Now I come to the clinical case 3, genitourinary RMS, which is from the case file in 2015. This is an 8-year-old boy. He was operated elsewhere for a right testicular mass about 4 months back before presenting to us. This surgery was done from the scrotum. No histopathology was available to us. He presented to us with abdominal distension for 1 month, which was progressive and painless. He had persistent cough, very poor appetite, and severe weight loss. He was basically very cachectic at the time presented to us. Anemic and very irritable. There was pedal and sacral edema, highlighting that there was probably hypoprotension. The abdomen was large, firm, irregular, with an irregular surface, and the whole of the lower abdomen, whole of the right side of the abdomen was filled with mass, which was crossing the midline. There was a large mass in the right inguinal region also. Now, again, we have a child who has some kind of a scrotal testicular mass, which has presented now either with recurrence or with residual disease. And how should we manage this? It showed anemia, which were corrected, in this patient, and the nutritional buildup was started. We tend to forget the nutritional buildup, which should be started as soon as we get the child and we start working up the child, which could be oral feeding or nasogastric feeding. Mostly TPN is not required because we can do with enteral feeding. Most common tumor in the test is a malignant germ cell tumor. A serum AFP was done, which was normal. Bone marrow studies were normal. Bone scan was normal, which will show in subsequent slide. And a core needle biopsy was performed from the inguinal mass. This is a CT scan of the patient showing the right inguinal mass, large mass in the right side of the abdomen, which was heterogeneous with the areas of necrosis and solid areas, multiple hepatic nodules, multiple nodules in the mediastinum. This is one of them depicted here, and multiple bilateral chest nodules in the patient. So right inguinal, retroperitoneal, hepatic, mediastinal, and bilateral pulmonary masses. And this is how this patient presented to us. This was a PET scan that done in this patient, which showed a very avid activity with the PET scan. The biopsy was done, core needle biopsy in this patient, which showed a embryonal rhabdomyosarcoma, most common. It was not a spindle cell type, but a simple embryonal rhabdomyosarcoma. So the final diagnosis in case 3 was a paratesticular embryonal rhabdomyosarcoma, which was either recurrent or progressive from the residual disease of the first surgery, involving the spermatic cord. And clinically, there was a left supraclavicular lymph node also, which was very large, which was also positive on an FNAC. This was clinical group 4, TNM stage 4, and high risk, obviously. Though it is a favorable site with metastatic disease, it becomes high risk. Patient was treated with VAC chemotherapy, developed tumor lysis syndrome early in the first course of chemotherapy in the week 1, which was managed with IV fluids, and rasburicase needed to be given to this patient to tackle the tumor lysis syndrome because of the very high uric acid levels which he achieved. The patient was reassessed for local therapy at 9 weeks. We do that at between 9 and 12 weeks. There was a very good response in this patient. So, 9 weeks with very good response, we did a rhabdomyotomy and spermatic cord in the inguinal region. That was done. There was a very small retroperitoneal lymph node residual which was left in this patient. Post-operative radiotherapy was given to this patient, and adjuvant chemotherapy was continued till 52 weeks, till August 2015. And the lungs had cleared completely. Now, we can discuss here the role of retroperitoneal lymph node dissection. It has been shown very clearly that in children less than 10 years of age, there is testicular rhabdomyosarcomas. It can only be considered as a or it should only be considered if after the completion of chemotherapy and radiotherapy have no viable tumor. As compared to children who are more than 10 years of age, they follow the adult protocol and they will need unilateral retroperitoneal lymph node dissection for having a cure. So that is the difference in the retroperitoneal lymph node surgery for these patients. So this child was CR or complete response at the end of therapy. The CT scan did not have any rectal lesion. PET scan was also negative because of the mass effect or obstruction in the beginning in this patient. He was disease-free at 8 years, 4 months after the completion of therapy in December 24 with normal renal functions, though the right kidney was still functioning poorly. So paratesticular rhabdomyosarcomas are usually painless unilateral scrotal or inguinal masses in prepubertal or slightly postpubertal boys. Lymph node metastasis is linked to the age. It is uncommon in children less than 10 years, and more than 50% of children more than 10 years would have retroperitoneal lymph node positive. And lymph nodes which are more than 2 centimeters on CT scan don't need to be biopsied. They're taken as positive. But if a child of more than 10 years has lymph nodes which are less than 2 centimeters to be biopsied initially to prove if they're positive or negative, because then the radiotherapy and lymph node dissection will be decided upon. Radical orchiectomy through the inguinal route is advised for these patients if scrotal violation occurs completion orchiectomy and injection is done according to the age of this patient. So this is paratesticular RMS, which is also common in, not so common, but can be seen in boys at in this age. This is another case from the 2015 case notes. This is a girl who's 14 years old with menorrhagia for 5 days. She had attained menarche 1 month back. There was a mass protruding out from the vagina with excessive discharge. General physical examination was within normal limits. Polypoidal mass was protruding out of the vagina, and the rectal examination showed a firm mass anterior to the rectum, which was bimanually palpable. Ultrasound showed about a 10 centimeter mass in the cervical canal extending to the body of the uterus with thickened endometrium. MRI scans were done in this patient, which is shown here, which showed a distended endometrial cavity with enhanced contents, which was hypointense on T1 and hyperintense on T2. And the CT chest, which was done non-metastatic tumor arising of the surgeon, also showed hypermetabolic lesion on the uterine lesion with left external and internal iliac lymph nodes. So N1. The biopsy of this mark showed of this polyp, which was hanging out, showed negative, and she was started on neoadjuvant chemotherapy, which was whacked again. This is the histology of this patient showing the embryonal rhabdomyosarcoma. Now, how do we stage this patient? So again, we go back to the charts. In fact, in our clinic, behind the on the first page, the staging chart is given. So we mark out on the staging chart. This is stage clinical group 3 because only biopsy was done. And because it is a favorable site, uterus, vagina, vulva, favorable site of RMS, limited to the organ of origin, more than 5 centimeters, lymph node positive, non-metastatic. And we're looking at the risk categorization of this patient. Favorable site, embryonal rhabdomyosarcoma is counted as low risk too. Now, it's very difficult to remember this, all this. So this patient, we continued the VAC chemotherapy. Now, unlike other rhabdomyosarcoma, the surgery for vaginal and uterine rhabdomyosarcoma is undertaken at the end. Because if you try to do it at week, end up doing a vaginectomy or hysterectomy and a vaginectomy, which is a very deforming surgery for these young girls. And it has been shown uterine rhabdomyosarcome. So she was again assessed, and then we had to decide whether we need to give radiotherapy or not. Now, radiotherapy to the pelvis also causes a lot of problem and can infertility, which is in addition to the infertility being caused by the cyclophosphamide. So we have to be careful. So this is midway in chemotherapy, very good partial response. The tumor had become very small. You can see the uterus in that side. And this is at the end of chemotherapy in April 2016, when there was a complete response and no tumor was seen in this patient. So she received VAC chemotherapy, which was completed, and the disease and has resumed normal menstrual cycles from 2016. At 9 years of follow-up in December 2024, at the age of 22 years now, she has normal growth and development and has graduated from college and is working somewhere, has normal renal functions and normal menstrual functions. So by doing this kind of conservative treatment and the uterus, and also give her a normal, near normal life. So uterine RMS, it is usually seen in older girls, pubertal and post-pubertal. They present vagina and they're usually embryonal rhabdomyosarcome. Now we come to another interesting case, which is from 2014 case notes. This is a small girl, 13 months old female child with bleeding per vagina for 15 days and a polyps projecting out to be embryonal rhabdomyosarcoma. Again, on staging, this was low risk 2 because the TNM1, CG3, biopsy only, favorable histology, embryonal rhabdomyosarcoma. So like all other tumors of low risk 2, she was started on chemotherapy. In fact, she had been started on only 2 drugs chemotherapy, VA, but then the disease progressed. We converted it to VAC. It's actually wrong. We should have started VAC from the beginning itself, but somehow she got started on VA chemotherapy. MRI and vaginoscopy done at 20 weeks showed a small 0.5 centimeter residue in the right lateral wall of the vagina. Vagina conserving resection of the was done with the right lateral wall, and reconstruction of the vagina by the primary vagina itself was done. No radiotherapy was given. She is disease-free at 10 years of age. Now, short infants in young girls with vaginal bleeding, foul discharge sometimes from the vagina, often mass protruding out from the vagina, and usually these are botryoid RMS. When you look at this site, vagina, uterus, and repeated vaginouteroscopy and chemotherapy, repeat examination, limited resection if required, and total vaginectomy and hysterectomy is preserved. Is only for children who are poor. So I tried to portray the genitourinary RMS, taking help of these 5 cases of different age groups in this patient, and try to show some of the long-term outcomes also. Both favorable and unfavorable sites exist in genitourinary RMS. They are mostly embryonal RMS, mostly unresectable, which can avoid mutilating surgery. Adjuvant chemotherapy with or without radiotherapy is must for all the patients of rhabdomyosarcoma, and outcomes, but long-term complications are there, and they have to be serially followed up, especially for the bladder complications or lower tract complications, because that will lead to upper tract damage also. Thank you.
Thank you,
So,
sir.
Dr. Archika.
Yes, sir.
Thank you, sir. Thank you.
The Dr. Pandey, Dr. Vijay.
Sir, thank you, sir, for your Nice presentation and nice elaboration of all the different cases. So we have few of the questions regarding fertility preservation for young children undergoing treatment for genitourinary rhabdomyosarcoma.
What is the
options? Fertility preservation.
I didn't get you. What is the
Fertility preservation option, sir.
So fertility preservation options are now offered, especially for children in the adolescent group. It has been just started for very young children, but successful. But yes, the ovarian or follicular conservation can be done for young girls, and it should be done. It is not so successful for boys. And unfortunately, cyclophosphamide is not a good drug. And we do hope some alternative drugs come up which will cause less fertility. Not all children become azoospermic. Some become, hypo, and some have very poor motility. So that will lead to fertility problems. In girls, mostly the ovarian follicles are conserved, even with cyclophosphamide. And so, but still, if it is a very expensive proposition, not very commonly done in India, but coming up in a big way. I know that in Sick Kids, Toronto, and all, there are a lot of work being done on this fertility preservation.
Sir. So next is large rhabdomyosarcoma in the trigone region. Incontinence or sir oncology control, what should be given the priority?
Oncologic control, obviously, because conserving life is the first thing. So oncologic control is there. Now, once this oncologic control, we need to see what kind of surgery is required, or is it required at all. And we know that external beam radiotherapy can also affect the bladder size and the pressure systems later on. So the more recent development in the last decade has been brachytherapy for bladder neck RMS, which has been very well described by Dr. Helen Martelly from Paris, and they do brachytherapy. And the wires are inserted under GA, and that gives radiotherapy to a localized area. But in spite of that, a large number of these patients, especially if they are operated, they will land up into incontinence, requiring CIC, and at times augmentation.
So next is regarding diagnosis, imaging versus biopsy.
Both are required. Imaging is done basically to look at the extent of the disease.
Sure.
Whether it is localized, what is the size, what is the organ of origin, and whether it is metastatic or not. Biopsy is done to confirm the histology. The current divided into embryonal and alveolar rhabdomyosarcoma. It is divided into fusion positive and fusion negative. The fusion positive RMS are alveolar rhabdomyosarcoma. But we also know that some of the alveolar rhabdomyosarcoma are fusion negative, and they basically behave like embryonal rhabdomyosarcoma. So biopsy is definitely required in all these patients. It depends on how we are going to get the biopsy, whether small tumors are primarily excised and biopsy is taken, or core needle biopsy. Core needle biopsy is a very good option with or without imaging guidance.
Sir, for risk stratification, any role of molecular markers?
Not yet. In the standard protocols of the various European and the American groups, the molecular markers are still not used. But as I said, the fusion studies are done, because if it is fusion positive, then they become high risk tumors. But other molecular markers are still not being used in the routine clinical practice.
Sir, one question related to the radiotherapy. There are long-term risks of secondary malignancies post-radiotherapy. So can radiation be avoided or dose amended in young children?
So radiotherapy, yes, we should try as far as possible to avoid the radiotherapy, and there are very specific guidelines in which patients radiotherapy should be given. Dose reduction is not done for small children, but yes, if we can avoid it in less than 1 year of age, then better. But usually these children are more than 1 year of age. And if we can give brachytherapy, then that is the best possible option. But then, as I said earlier, conservation of life takes precedence over conservation of lower tract functions. But in the eyes of the parents, it is an important factor, and we have to explain to them. And unfortunately, if we try to explain too much about incontinence and infertility, we have to mention it. But if we say too much, a lot of children will not take any treatment.
Yes. Sir, we have got one question in the chat box. Is it possible to pinpoint the site of origin as prostate or bladder? And prostatic RMS considered under the broad headings.
So that is why it's called BP, bladder prostate, because at times it's difficult whether it is in the trigone alone or trigone and prostate across the bladder neck. It is difficult. But as I said, as I mentioned in the review of literature here, that most prostatic tumors are very large and they have a higher propensity of being metastatic at presentation. It does not make a difference in the treatment because whether it is trigone, bladder neck, or prostate, ultimately the surgery will result in the similar kind of outcomes and the treatment is the same. So it is not important.
We have one question from Dr. Akshay. If we were to perform RPLND in adolescent patients, then why lymph node sampling for lymph node below 2 centimeters?
Right. So I said that if the lymph node, if now we're looking at children less than 10 years or more than 10 years. If in less than 10 years child, if the lymph nodes are more than 2 centimeters, we take it as positive. And if the lymph nodes are less than 2 centimeters, we take it as negative. But in children more than 10 years of age, if the lymph nodes are more than 2 centimeters, we don't biopsy, we take it as positive. But if lymph nodes are present and they're less than 2 centimeters, then we have to biopsy them to prove whether they're positive or negative. And then the further treatment will accordingly be required. So in these patients, if after chemotherapy, neoadjuvant chemotherapy, if retroperitoneal lymph nodes are still present, then either we can do retroperitoneal lymph node dissection or we can give radiotherapy to these patients. Both are bad, but then that is how the treatment is. Most of the adult papers will tell you about retroperitoneal lymph node dissection and its complications like ejaculation and erectile dysfunction and other complications of RPLND.
Sir, we have another question from Dr. Kaushik. Do you do genetic studies like PAX3 or FOX01?
So again, it should be done. That is what I said, fusion studies. That is the PAX3, PAX7, and all the fusion studies. So in one heading, it is called fusion studies. So it has to be done to. So it is not only routine H&E stains and IHCs, which are important in these patients. Now fusion studies have to be done to actually properly categorize these patients.
Another question from Dr. Hira is, what if the microscopy shows positive margins and what is the role of proton therapy?
I can't hear the question.
So what if the microscopy showed positive margins and what is the role of proton therapy?
So there are two different questions. If microscopic positive margins after resection becomes clinical group 2, and according to the staging will change if you look at the chart, right? Proton therapy is a type of radiotherapy. It has not been shown to have any definite advantage in children with proton therapy. It is a very expensive proposition, and the time period for which proton therapy has been around is not very long to show us any specific advantage in this site. Brachytherapy is a much better way of giving the radiotherapy than trying to go for proton therapy.
We have another question from Dr. Sagu. In case of recurrence, upfront surgery or chemotherapy?
Yeah, in case of recurrence?
What upfront surgery or chemotherapy is preferred? What is preferred?
So if there is a recurrence which is resectable, we should resect it and then give alternate chemotherapy, which in our institution is ICE chemotherapy. While if it is large at the time of detection of recurrence, then it is probably better to give alternate chemotherapy and have chemo reduction in the patient and then try to do surgery. Often the surgery will be mutilating, often we'll land up with cystectomy and or the loss of organ in these patients. But again, conservation or preservation of life takes precedence. And so all that, so to say that mutilating surgery should not be in RMS is a wrong statement. It may be required. And as I said, the literature shows that only 2/3 of the patients, we can conserve the organ. And this conserve the organ is also within inverted commas, an of the organ may not be physiologically conserved organ, as I showed in the first case.
Yes. Dr. Anand Pandey.
Sir.
Please.
Yes.
Any question from your side?
Sir, in AIMS, do you give chemotherapy in pediatric surgery or pediatrics patients are transferred to
Do you
pediatrics
give chemotherapy?
department? In case of chemotherapy, sir, all these patients.
So historically, for all solid tumors, Department of Pediatric Surgery has been giving chemotherapy right from late 70s. And we
Yes, sir.
still continue to give chemotherapy because for many, many decades, we did not have pediatric oncologists. So we would give the chemotherapy for all solid tumors, bear the burden of its complications, do the surgery, do the adjuvant chemotherapy, and follow up these patients. We are still doing the same, though now we have a pediatric oncology department, which is gradually picking up a number of cases which come to them and give chemotherapy to these patients and send the patients to us for planning of surgery and doing the surgery.
Okay, sir.
Swaminathan, any comments?
No, sir. One comment regarding the fusion studies. So there is recent guidelines saying that all fusion positive patients, even if they are group 1, requires RT, even if the margins are negative.
It requires
And
RT.
requires RT, radiotherapy.
At which site?
Any site, if it is a fusion positive RMS, even if it is group 1. And
Yes. Fusion positive, if you go back to the charts and look at it, they all become high risk.
yeah,
Even
so
if it's
those.
group 1.
So
They will require RT. They will.
So
Fusion positive basically saying in the old scenario, alveolar RMS. They have a very poor outcome, but fortunately, alveolar RMS is very uncommon in genitourinary sites. Very uncommon.
Yeah, so in these sites, the alveolar RMS are very rare. Yeah, they are favorable histology, but still they are unfavorable because of the difficulty to surgery or difficulty to operate.
No, the unfavorable in the alveolar RMS is not because of difficulty or operate. It is unfavorable because they have a very high propensity for recurrence.
No. I'm saying about the bladder RMS.
Bladder RMS, alveolar histology, I have still not come across any patient. They may be there, but I have a couple of paratesticular RMS which are alveolar, but not bladder RMS. And if it is alveolar RMS, you have to give radiotherapy. Most of our patients, because they don't undergo resection, as I said in the presentation, would get radiotherapy for these patients. Unfortunately, we have still not been able to set up the brachytherapy for these children.
Okay.
And brachytherapy is done at AIMS for adults for a lot of.
So in TMH, brachytherapy is done routinely
Yes,
for
I know that.
children.
I know that.
Yeah. In TMH, it was done.
I know that. It has been done for a long time. But I don't know about the bladder prostate RMS is brachytherapy is being done in TMH. I know about the extremity and the trunk RMS where brachytherapy is being done for now many years.
So bladder prostate brachytherapy is not done, but for vaginal RMS, one child had received brachytherapy. So
very good.
Sir, I have some couple of questions, sir. Like in this era of PET-CT, do we require to do a bone scan and the skeletal survey to work out for the metastatic workup?
Pardon, I couldn't get the question.
Now, when PET-CT is available, which can detect the metastasis, do we require to do a bone scan or skeletal survey for the metastatic workup?
Can be replaced by a PET-CT, but unfortunately, PET-CT skill is the sensitivity of PET-CT is not still very clear, especially in the genitourinary tract. In the bladder prostate areas, there's a lot of overlap. So the PET-CT may not be a good idea. For metastatic sites, yes. So a lot of our patients now don't undergo a bone scan and a bone marrow studies, and they would undergo a PET-CT. But that is the situation. We still don't have the literature out there clearly saying that PET-CT is something which can replace all the other studies. But that is being done in most places, yes. But PET-CT to evaluate primary tumor at the primary site is a very good, very bad study for genitourinary RMS because the bladder overlaps.
Sir, one more question. When you are giving a like bladder prostate RMS or a vaginal RMS after chemotherapy, and before it goes for a complete remission after 9 weeks or 12 weeks of chemotherapy, if some viable tumor is there, you can go for resections and further go chemotherapy because most few do complete response and no recurrence. But when they recur, there is a very difficult to treat them.
True.
So is there advisable to go for any local control after a partial chemotherapy 9 to 12 weeks, then do the local control where it can be resectable? And
So the protocols are very clear. In rhabdomyosarcoma, reassessment for resection is done at 9 weeks. In Ewing sarcoma, it's done at 12 weeks. Now, it is known, especially for retroperitoneal RMS and for extremity RMS, that if there is nothing left at 9 weeks, it's difficult to get a clearance. And we don't know what to resect, and the recurrence rates are higher. Yes, for those sites, it is recommended that one should go for surgery. If you look at the Western literature, a lot of Western literature is there on surgical resection of the bladder and the vagina and the uterus. Unfortunately, or fortunately for us, and I presented this way back in 2015 in the conference in Toronto, SIOP conference in Toronto, that a lot of our patients refused the surgery when they were explained the complications, and because of which we were forced to continue the chemotherapy and maybe add radiotherapy, and got equivalent results, outcomes at the end. Equivalent survivals, long-term overall survival, recurrence-free survivals. So I have really started to question the need for trying to do surgical resection early on.
So agree, but few of the patients do, I think maybe 70% do complete remissions goes on with continue chemotherapy. But few patients who recurs are very difficult to treat them. So
Yes.
I don't know which are that group.
Recurrence is difficult to treat always, and recurrence will be there in a certain percentage of the patients, and they will require extensive surgeries. But the alternate chemotherapy is also very good. So if you have a good follow-up of these patients, the recurrence is usually in the first 12 months or 15, 18 months of completion of chemotherapy or during the chemotherapy itself. So we need to have a very tight follow-up. So if as soon as you detect a recurrence, a small recurrence, you should go in or give alternate for 3 to 6 weeks and go in and resect the patients when they are resectable. But I agree, at times it is difficult because these patients may have got radiotherapy also, which causes a lot of adhesions and fibrosis in the pelvis, and sometimes it's a very difficult surgery.
Thank you, sir.
Sir, Dr. Suhasini has one question. Dr. Suhasini, please.
Huh?
Hello, am I
You
heard?
have some questions?
Yes, please.
Yeah, yes.
Good evening, sir. Yeah, I had two questions actually, sir. We were faced with a situation in I think 12-month-old female child where it was in the pelvis, sir. The mass was in the pelvis, and we had initiated on neoadjuvant chemotherapy. And after once it became resectable, we did a cystoscopy, vaginoscopy, and a laparotomy, but we did not find an organ of origin. There was some twig entering somewhere behind the bladder. So we couldn't really label the organ of origin. So have you faced a similar situation? And if so, how would you, what would we really tackle it as? It was a female child.
So no, I have not faced this, but sometimes it arises from the pelvic muscles and rhabdomyosarcoma. And there is no organ of origin is not the bladder or uterus or vagina. And we look at the presentation, sometimes large pelvic masses are very difficult to locate the organ of origin. And then if they disappears completely after neoadjuvant chemotherapy, it is still very difficult. So in that situation, we still go ahead with the chemotherapy, give the pelvic radiotherapy, and hope for the best. We don't know the organ of origin.
Yes, sir.
In fact,
yeah, sorry, Dr. Jindal?
Yeah, continue, then we'll say.
So one other question, your case one, you had described that you had gone in for upfront surgery. It was a fairly large mass. So I was just wondering, because the child, were you prepared to come out by just doing a biopsy, or would you advise to go in with upfront surgery in such a large mass?
I agree. If it was today, then probably I would not have gone for upfront surgery. But that was in the beginning, in those years. And we were very worried about this huge pedunculated mass, which we were worried. And that had extreme amount of pain. It was not getting relieved. And for that reason, we had gone in. And yes, we were ready to come out. Yes, we were ready. But it was a very small kind of attachment to the dome of the bladder. I still remember this case. This was less than a centimeter of the dome of the bladder that we took off, and the patient did so well. But it was a large mass, yes.
It was a pleasure listening to you, sir. Thank you.
Any other question from anyone?
Just one query, sir. Not a question basically. Does RMS and sacrooccipital mass also can be a differential, and RMS can be a differential diagnosis? Because one case I see and they have lost to follow up, like not get treatment after diagnosis.
RMS, I didn't get
So,
it was breaking.
sacrococcygeal mass as a RMS.
So true presacral or retrorectal mass usually will not be an RMS. RMS of the gluteal region protruding into the pelvis through the sciatic foramen and through the obturator foramen. But yes, they will regress back into the gluteal region, unlike the sacral mass.
Okay.
And sacrococcygeal teratoma, if it is there, invariably it's very uncommon to have normal AFP in these patients.
It's not a classically central one. It's like a eccentric location.
True RMS of the sacrococcygeal region, it can be, but I have not seen one. I've seen neuroblastomas, which is retrorectal, arising from the organ of suprafrontal and diving down deep into the retrorectal space, but not RMS.
Right. Thank you, sir. I think it's an excellent talk, and we are very delighted to.
Can I ask few questions, sir?
Yes, please.
Sir, what are the long-term upper tract status in these genitourinary rhabdomyosarcoma? And is urodynamic study required in every patient during follow-up?
What studies? I didn't get you.
The urodynamic study.
Urodynamics. So yes, I would say now after a lot of studies, and we did this for germ cell tumors also and for rhabdomyosarcoma also, yes, urodynamic study should be done in all patients who have got cyclophosphamide. If they're normal, especially if the upper tracts have shown hydroureteronephrosis, then one must suspect. And if the ultrasound shows a small bladder, and if the patient is having symptoms, yes, you must do urodynamics. We would do urodynamics in all survivors at 1 year after completion of therapy to look at the bladder profile. And we would, if it is not good, we would do it repeatedly also.
Thank you. So one more question is, so we a few years back we found a case of vaginal rhabdomyosarcoma botryoid type, and that has filling the whole of the vaginal cavity, and it is not responding to that VAC regime for 10 weeks. Then how to proceed in such cases?
So if it is not responding, then obviously either you can change the chemotherapy to ICE and see. We had one patient in which we changed the chemotherapy and responded very well to ICE. But otherwise, you will have to go in and resect the patient, and which will mean total vaginectomy and replacement of vagina using a bowel loop, or it will need vaginectomy and hysterectomy and leaving a for later age. It's better to leave the reconstruction for later date because you will have to give radiotherapy also. So it's better to just do the resection and leave the reconstruction for a later date. But ultimately to save the child, currently we have a patient with us. I saw that patient today also who had very good response, and there was just a nodule left in the vagina which we biopsied and it was negative. And now she has come back with a huge recurrence in this patient, and we have sent the patient for an alternate chemotherapy. Today only we have seen, this is from the National Cancer Institute, and we are treating these patients, rhabdomyosarcoma of the vagina.
So one more question from Dr. Sunita is that she has asked, many centers don't have facilities for the fusion studies. So and what to advise them, how whether they should be referred to the current area or manage at on center?
So I would say in today's day and age, yes, you should have some linkage with some other center like Tata or somewhere where you can send your histology blocks for review. But till about 5 or 10 years back, everybody was reporting on routine histology, alveolar histology. And so what you lose, most people will be able to diagnose alveolar histology. Some of these alveolar histology will be fusion negative and behave like rhabdomyosarcoma. So you land up over-treating this small group of patients who are like normal H&E, looking like alveolar histology, but are actually good prognostic, and they could have avoided the radiotherapy to these patients. It's a very small group of patients. So it's not something that a very big concern. But yes, if you can develop links to send the blocks for review, it is a very good idea.
And so Dr. Lucky asked that, is familial counseling required by genetic counselor or should be done by ourselves, sir?
There is no family counseling. There is no familial counseling routinely done for rhabdomyosarcoma patients.
Okay. Sir, so if any other question, it's okay. Otherwise,
No other questions. I think it's already time also.
So it's a very nice and sir, excellent talk, sir, as
Thank
always.
you.
And you certainly represent your wide spectrum, your experience with wide spectrum of the rhabdomyosarcome, genitourinary rhabdomyosarcoma, and totally enjoying. Everyone has enjoyed your talk, sir.
So I'll take this opportunity, everybody, and also a little bit propagate that we are going to have a master class in pediatric surgery oncology on the 21st and 22nd of August this year at AIMS, and all the tumors will be discussed in the same format that I've discussed today, taking cases, 2 or 3 cases, Wilms tumor, neuroblastoma, hepatoblastoma, germ cell tumors. All the master class experts will discuss all the talks in the same format. So you're all welcome, and the details will soon be there on the WhatsApp various groups. Thank you,
sir.
Thank you, sir.
Thank you very much, sir.
Thank you very much, sir.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you
Thank
for
you all the moderators and for taking